All right, so going over neurological emergencies tonight, chapter 17. So for some of you that are following in your books, y'all will be able to go over here. So kind of want to start off with a funny so you guys can understand. And I'm sure that you guys at some point in time have heard this, have gone over things, 14 things that you never want to hear from an EMT or a medic. Hopefully it works and I can get things to work right. Well, obviously it's not going to work. So when you get time, just look that up from Firehouse Coffee and kind of go from there on you guys, so you can see the 14 things that we never want to hear. Obviously, I'm having some computer issues tonight, so we'll. All right, let's see here. Let me move this box. All right, so medicine. Break down some of the stuff we're going to go over tonight. We're going to follow. Um, We're going to do medicines and applies the fundamental knowledge to provide a basic emergency care and transport based on an assessment. That's going to give us our overall knowledge of why we have medicine, what it's going to use for. I know we talked about this as we broke the medicine part down, but it's just we got to hit these core components all over again so everybody's aware of what we're going to do and we're kind of going through the chapter. All right, so neurologic is anatomy, presentations, and management of decreased level response. So you can do decreased LOC, level of consciousness. They can have it from seizures or stroke. We're going to go deep into this about the seizures and stroke, kind of make everything goes a little bit further about that. Let's see here. So the anatomy and physiology and the pathophysiology of assessment of a management of either the stroke, you can have transient ischemia attack. You'll have a seizure, status epilepticus, which means they're postictal from a seizure, or they've had multiple seizures. So that's where your status epilepticus comes from. And a headache. Some of the ones that suffer from headaches that maybe here in the class, you'll understand some background of what the stroke is and why it's listed in this as a headache. So fifth leading cause of death right now is a stroke. Um, so a lot of the times you can have a spontaneous hit you out of nowhere stroke. You can have a bleed that causes it, subneurachnoid bleed, and all these other things that are caused by strokes. And I'll say men, mainly going to talk about myself, we really just don't pay attention to these things and what could be causing them, why we want to go address them, and like the non big factors of stroke signs that can affect versus hey, look, something's wrong, I'm hurting, this is not normal, and we go to the doctor for. A lot of times we'll shrug it off to be, and I'm tired, I worked hard today, I just got a bad headache for a couple of days. Some other contributing factors for a stroke includes family history and race. If it's a predominant in your family to where they've had strokes in the past, and we need to know that as providers. Ask, hey, is there any pertinent family information that is out there that I need to know about? Um, mom's had diabetes or dad's a cardiac patient. Things like that is very important. Uh, Certain hospitals are stroke certified centers. The faster we recognize it and the faster we transport out into the field to a stroke center is very, very helpful. I'm actually trying to check. There is an app that we use on our local ambulance side. Uh, Obviously, I've deleted it since oh, there it is, Pulsera. So I don't know if you guys are used to Pulsera or if anybody's ever used it, but it's an app that we use in our local area to where it alerts our stroke facilities about what we have, how old. It is kind of in depth on answering those questions and trying to get it out there, but it does give a lot of information to these receiving facilities prior to getting there. So people have the information out there, uh, but en route to the hospital and the facility, it's nice. It's to be able to have that app, or you know, I keep jokingly say, even in the fire service, you can have a fireman fill it out. It's that easy. So I'm not being ugly, and I know it's fireman friendly. We can all work from there. All right. So seizures, altered mental status may occur. So we know we've all been around somebody that's had seizures or we've seen seizures. And when people get that, has anybody in the class ever had like that 1,000-yard stare where you're just stuck staring off in space and you just can't like snap out of it? I'm sure y'all are all typing. That's the reason why I asked that question. But when you have those, that is a form of a seizure. It's a brain misfire. It's a functionality thing that causes you to just have that off the wall stare, and somebody's like, "Bruh, you paying attention?" So if Robin, on your son, when you're saying your son has them, but are you meaning seizures specifically, or like that the 1,000-yard look stare? Yes, sir. But my dad has had them. Seizures are pretty serious.
He's had the staring and he had the grand mal one time, but he's on medication for it.
Okay, so was that age specific? Is they thinking he's going to grow out of it?
I'm hoping he grows out of it.
I do too. That's a scary thing. I'm sure as a parent to have to deal with that and go through that. I'm sorry to hear that, Travis. Same thing for your dad. Um, so the seizures can be results of multiple things. Traumatic brain injury, it can be genetic to where it's built in that way from the family. And it's not like we're trying to pass on bad juju, but we can't fix that. Could be a metabolic problem. Could be the brain tumor that is unseen at the time. They start growing to certain sizes and starting pushing on the brain, creating internal pressure. Something has to give. And a sign and symptom that may result that it is from a seizure. Um, so it's a possible cause: altered mental status, intoxication. Um, we've all, I'm sure, out of the 14 that's in the class, at some point in time, we've all had that altered mental status due to intoxication. But on this, it's more of a serious factor than your once in a blue moon. For head injuries, you know you're going to have altered mental status because they've just got the crap knocked out of them. They may have been in a traumatic injury, so expect that when you ask your questions, if the questions are not answered correctly due to the incident, they could have a TBI. Hypoxia, bro, like we said before in respiratory section, I'm a fan to breathing, so if I don't have no air, I'm probably gonna get crazy too. Stroke's gonna cause altered mental status also, so think about that. That could be a sign and symptom of things. Um, Metabolic disturbances, bro, there's so much out there these days that are causing issues, and it's just a lot of things that we as EMS providers are supposed to be broad knowledge of, but a lot of times they don't teach us. They just expect you, and you learn them over time and throughout your career, and you just pick up these things in there. So your treatment varies widely depending on what kind of issue you've had. On a stroke, as a basic, you make sure that you give them everything they need. High flow O2, you comfort them and recognize it and get them transported to a facility faster or to ALS provider. So depends on the head injury also. If you're able to treat the other symptoms, you don't want to move them around anymore. Protect their head even more. Intoxication, have patience. That's the best I can tell you for that. Keep your distance. Have patience because they may become combative on the due to the intoxication. So we know. I mean, brains are computers. We talked about this the other day in the sections of respiratory. How you don't have to do nothing. Your brain automatically starts breathing. Does it on its own. Our speech pattern. I get caught up pretty bit on when I say certain words. I'm like, I don't know where that came from. I don't know what just came out of my mouth. I say it's my brain's fault. Then I'm the one who's trying to make it work. So then all your body functions. Think about it. Every little single thing you do, no matter when you talk with your hands or your lip motions, your facial expressions, your computer in your brain is making every bit of that happen. With some injuries, you may not be able to do that. That's why sometimes the stroke creates weakness on one side of the body and you may have drooping on the other. So think about that. Their computer, we can't reboot their computer with Control Alt Delete, but we can recognize those signs and symptoms early and do our best to treat those as fast as we can. So we know the major parts of the brainstem is the cerebellum and the cerebrum. So you see what's the big part. I mean, the cerebrum is the biggest part of the brain, and that's the most one that we want to be cautious about. That's the reason why we always tell everybody wear your helmets when you ride a bike, motorcycle, these certain things, because we don't want to mess up our computer. We got to protect it. So you see right here on the diagram, I'm trying to get my mouse to rolling over. So you see all of this is very, very important. That's your soft tissues. When you have a stroke, you can get bleeding in here, your pressure. It can only go so far. Like I've told you before, my brain is full of useful knowledge. So about all of this is full of useful knowledge, and I only use probably like that part right there. That's it. No, but on the serious note, that's all this functions and carries and works everything else. Your hard part of your skull, if you happen to get hit or have an open a brain injury, they may have had to remove some skull for swelling, and then you got a soft spot. Babies when they're born, we all know we have that little soft spot on top of our head. You come down here, your brain stem is in this area, your spinal cord. Any of this right in here gets cut, severed, damaged, or anything like that, you can be brain dead. Or from other injuries, it creates a whole lot of issues that you gotta try to get worked out. So there's just a diagram of some of the things we're going to talk about, so y'all know the physiology of it and where it's located as we talk about these things. All right, so the brainstem controls the most basic functions: breathing, your blood pressure, swallowing, pupil constrictions. All those things are done without us even having to think about it. Let's see. Walking, writing, picking up coin. That's your fine motor skills. That's your movements. Is controlled by the bigger parts of the brain. So we need a lot more area to cover when we start working on your bigger sections. Walking's a pretty big thing. I'm pretty sure right now that I want to make sure my brainstem works because again I'm addicted to breathing, like we've talked about multiple times. And just pupil constrictions. Is it bright light? Wow, that's so bright, my eyes have got to contract a little bit. So all those things are done, and the best part about it is we really ain't got to do nothing. We just walk, talk, and breathe. The cerebrum is divided into right and left hemisphere. So each one of these contains activities of the side of the body. So like I think it breaks it down in here. I think you break it down a little bit in a minute. But the front controls the emotions and thoughts. So if you have like frontal brain damage, some people say, "Oh, I had brain damage there, and that's the reason why I just say what comes to my mind." Well, I guess kinda, because your thought process may not, work correctly, and you just say kind of what the hell you want to say. So your middle controls your sensations and movement. Sensation as in touch, heat, cold. Do I need to move my arms? Do I need to move my legs? How does that need to work? Moving your head. And then the back's processing the sight, make sure your eyes function. We talked about eye movements, all these other things that certain parts of the brain are all going to work on. And that's how it's broken down. Each part has their best little bit, and they all work in tandem with each other. So if you need to move your left arm where you get to see what you're moving it to, you're reaching out to touch something. Now you got to know your depth and all that stuff. So when you get into the brain functionalities, it's so a lot. I've talked with a couple of brain surgeons that work at UMC here in the Jackson area, and it is super, super deep, and they want to go all of these different avenues, and you're just like, bro, I'm just asking if you think they're gonna have brain injury. I don't need to know about what such and such area is firing. So it's kind of neat to talk to them, but at the same time is they talk a lot and very deep. So in most people, speech is controlled to the left side of the brain and near the middle of the cerebrum. Messages sent to and from the brain travel through these nerves. So that's the reason why we talk about the path of the nerves. If any part of the spinal cord is messed up, because each little fiber controls certain areas, we want to make sure that we're very careful of that. Um, when it talks about the 12 cranial nerves, they run directly from the parts of the head to the eyes, ears, nose, and face. Each part of the nerves have their different duties, and there's certain responsibilities on things. So that's the reason why they all have certain numbers, so you know exactly where they're headed to. And if it's one of them's affected, then they know what area of the body is going to be affected. That is, sorry guys, I'm trying to type in something too so I can get some other information brought up, and that's what I'm trying to get on the side over here. So if I'm stuttering, that's why. I apologize. All right, give me just a second. I'm trying to see if I can type something in. All right, so the rest of the nerves join the spinal cord, so it creates our, I like to call it an umbilicus. So everybody kind of knows you get your umbilical cord when you're born. That's your functionality until you're able as a baby. They cut it and you're able to work on your own. But it has an umbilical, and if we cut that umbilical, then every part of us is damaged. I mean, you could have damage to your sensations, or you not be able to move when you're supposed to due to extreme heat, or your function of your brain because that the disruption of your nerves. So that's why it's so important if you have a spinal injury, hopefully that there's no disruption of the path of the spinal cord, because it can create lifelong injuries and and issues that we got to worry about. So here's the breakdown a little bit more. Your cerebellum and your cerebrum. There's your brain stem you see right here. This is considered all parts of your spinal cord. And then y'all know spinal nerves go out from the spinal cord throughout the rest of the body. Go every single place that you can think of. And they basically, I say, they reach out and touch you. That gives you all your information. That's your core. That's all your little fibers running out from your umbilicus. So that's what really makes us function with your brain up here, thinking of every single thing and firing to all these. And I don't even want to say milliseconds because it's so much faster than that, that sends out what to do, how to do it. Oh, that's hot, and you jerk away within tiny seconds. So it's pretty neat. We can go depth into that, but I'm gonna tell you, I'm not the guy to teach you all those things on how it functions as fast as they do, because of how detailed they go. So the pathio about this is uh, many different disorders may cause brain dysfunction, may affect the patient's level of consciousness, speech, and voluntary muscles. So, like with a stroke, you may have the smooth muscles of the face that are affected, that they're going to droop to one side or the other. If you ask somebody a question and they don't answer it real well, they're like, "Hey, can you tell me what day of the week it is?" It's purple. Their brain is telling them that, and they hear exactly what you're asking, but they can't answer it right. They try their best to, and that's the reason why you have to work with them, because they can get frustrated really easy. So that's where your brain is starting to have issues because of the bleed. So the sensitivity and the oxygen, the glucose, and the temperature. So the colder they get, they may go start hallucinating. They've had some really big things in the past where I watched it was like in Alaska, a group of explorers went out due to the sub temperatures, and their brain started telling them that they were hot, and they all stripped naked, and they actually found their bodies, but nothing was wrong with them. So it was the lack of oxygen and the temperature which made the brain think that, oh, I'm burning up, because when they're freezing, they lost all their sensations. So that's what the importance of having the oxygen correctly, deliverance, and not depleting of it, that they think functionality. But due to some situations and the lack of all of these, your brain's going to tell you things that's not really there, or you're not thinking straight, or you're on a complete different path. Some of the general rules are, let's see, if a problem is caused by disorder in the heart and lungs, the entire brain is affected. And the primary problem is the brain, only part of the brain that is affected. Um, so any part that starts to affect the heart and lungs, we're going to have issues there, because that's your computer is misfiring. It's not reading the disk that's set in there that we need to work off of. So that is important. Um, if they're saying the heart and the entire brain is affected, they're going to have a lot more issues that we can fix as an EMS. Their provider is just the best thing you can do as a care provider is get them to the hospital. And a higher level of care is the utmost and most important thing that we can do in the field, is get them to the most appropriate facility in the time manner that we can. All right. So in a headache, it's the most common symptom that we come across. They can be a symptom of another condition or a neurological condition of its own. So a lot of times, as we'll say, is a headache, a continuous headache, may be due to high pressure of the brain. Their blood pressure may be up. They may not be able to think properly because of the pressure, and all they can do is have a headache because there's nowhere for everything to go. It is it is super tight in there, and they can't breathe, and they just have everything builds up, and they just have trouble with their head hurting. So that's the only thing they can complain of. So only small percentage you see right there is of headaches are caused by a serious condition. It's always a secondary complaint. Um, it's like a referred pain. So kind of off topic real quick, but if you have referred pain and let's say my jaw starts hurting, I'm starting having issues in my jaw, and it could be related to having chest pain. So your chest pain's coming in, and that's a referred pain is to your jaw. So that's where we start like, oh, well, what else is wrong? Let's think about this. Let's think outside the box and go this area. So headache could also be considered as a referred pain. I don't know why it's not. There it is. So tension headaches. Unfortunately, I mean, living in the South, I've dealt with headaches forever. I've had migraines so long as I can remember. Sinus headaches. Everybody knows when the season starts changing, you're gonna get a headache. Period. Not happening. They're not life threatening. They can be. I've known people that's had headaches for months at a time that's debilitating that unfortunately they can't deal with anymore and they harm themselves. Um, but migraines, I at one time I was keeping up with them. I would had in the upwards of 30 a month, and thank God I was able to get on a shot, a once a month shot that's taken mine drastically down to where I can function and continue. I say as the best human as I can be, but I can function like everybody else and make things work. So tension headaches is caused by the muscles contracting the head or neck. That's where everybody starts rubbing their necks around, like, oh God, it hurts back there. Stress is a huge cause of this. That's where you tighten up, like your neck just tightens up so hard. Um, People can describe their pains differently on there. It can be, I'm having, oh my God, it's just super tight, so it's squeezing. They may have like dull pains, it's just all over. It's not like a sharp pain, like where you get stabbed or anything like that. Hopefully nobody just gets stabbed on a regular basis, but you kind of know what I'm talking about. Most of the time, you don't have to, treat them with medical attention or to a facility, but sometimes some places people do require to be taken to the hospital for these. Hopefully, and the way that things are right now, we can probably talk them out of that due to the status of these medical facilities, and that we can kind of be like, you don't need to go for that, but here's some things you need to do. Sometimes people have them caused by dehydration. Heat is a big cause of those. Migraine headaches thought to be caused by change in blood vessel size in the brain. So it also could be because of their blood pressure super high, that it's uncontrolled, and now they're having to do something with that. So high blood pressure may be the problem for that. You A lot of kids nowadays are getting it, and it's also sometimes related to their their eyes. Their eyes are they're squinting at the TV and stuff like that. So that's an issue. Um, let's see. Pain is usually described as a pounding, throbbing. Guys, we've all had these massive headaches that you just like. I can't function. I don't know what's going on, but I can't function with this headache. I've had some last for a couple of days. I've had some that I don't want to be around nobody. I don't want to talk to you. I don't want to look at you. I'm hurting. A lot of mine were caused by once I got the headache, the heat. I mean, I'm sorry, my eyes. I couldn't have a lot of bright lights, so that was a big issue on me. I'm just using myself for example because I know a lot about headaches because of myself. Sinus headaches is caused by pressure that's resulting from fluid behind the sinus cavities. Um, you, as a EMS, you don't really, you ain't gonna do nothing because you really can't do nothing from more. There are sinus headaches. It's changing the season, pollen, and all that stuff is going to it's gonna get things worked out. I mean, we all know that these are gonna take place. So uh, it is what it is. I'm sorry, when it comes time to season change, it sucks. Uh, let's see, serious conditions that include headaches, symptoms or hemorrhagic strokes, brain tumors, and meningitis. That's a big one. Meningitis can also affect it in a really big way. Uh, so let's see. Be concerned if a patient complains of sudden onset severe headache or sudden headache that has associated symptoms. Somebody that may have traveled outside the country recently, I'm not talking about COVID related. Um, the increasing of the internal cranial pressure may be caused by hemorrhagic stroke, tumor, or related to a head trauma. So recently, like if you can ask your patient if they were recently involved in a motor vehicle accident or they had some head trauma, maybe recent onset of seizures. That may be some questions to ask if their headaches are starting, if they've just suddenly got debilitating headaches. That should give you a couple of answers. I'm sorry if you hear my dogs in the background. Obviously, they're trying to let me know that they've missed me and they just won't stop barking. But what can you do? It's dogs, and I'm just going to have to try to talk over them. So I apologize. So strokes can also be called CVAs. You may hear them saying that out on the radio. Party two for CVA. It's the same exact thing as a stroke. It's loss of lack of oxygen. The brain cells stop functioning and begin to die within minutes. We talked about that in the respiratory part. Um, and if you don't have enough oxygen delivered in the right amount of time, then it's gonna start dying. And after that, sorry y'all, my dog just came in and almost took me out. They're gonna die within minutes, and you're not gonna get that brain back. I mean, that part of the brain is not coming back. So if we can keep that from happening, the better off we are. Um, so that's kind of provide oxygen as much as we can. If we realize that they are having a stroke, go ahead and put them on a nasal cannon, a non-rebreather, 15 liters a minute, and rock from there. That's very important that we try to oxygenate them as much as we can, and uh, provide first aid or BLS care until ALS provider gets there. And there's really not much that an ALS provider can do until you get them to a higher facility because it's in the brain. I can't fix that. So rapid transport to the most appropriate facility is the best thing you can do. So as you see right there, ischemia develops inside the brain. That's another thing that we're just not going to fix. So if we can give them the oxygen and don't deplete their bodies, it's fine. Um, if they are depleted of oxygen, it should take a couple of hours for it to get there. But at the same time you may notice it, and it may be because of that, they may be at home for several hours prior to you seeing it because nobody was with them and they were. I'm sorry, I'm trying to click on what I needed to be going with anyway. And now you're getting them on the back side of it, so that sucks for us, but we have to treat them in the best way that we can. So we're getting them to a most appropriate facility in time. That's the best thing that we can do for them out in the field is recognize it early and treat them as fast as we can. Give me 1 second. I finally got opened what I need open now. All right. So there's two types of strokes that we need to go over. It's ischemic and hemorrhagic strokes. Oh, I told y'all the words have got me tonight. So we're going to talk about ischemic stroke first. It's most common cause. It's the most common one. 80% of the people that have strokes are going to have the ischemic stroke, and we can't tell the difference in the field. But what we're going to try to do is recognize the stroke as fast as we can, and then we'll go from there. Transporting them to the most appropriate facility is the best thing that we can do because they're the only ones that's got the medications to treat that stroke. Symptoms range from nothing at all because they may not notice it and it's just bam, boom, they bled out. they don't wake up, or they have complete paralysis because it has completely blocked them. You may not know it at all, and then unfortunately you get dispatched to a cardiac arrest, and it's from a stroke, because it could be small and then lead into something big. If you see right here on the stroke, is what they're talking about is on the clot, and it's talking about plaque that forms inside the walls of the blood vessels and may obstruct blood flow. Because you notice right here when I'm trying to circle, is that the clot's there. So all this area in the dark purple is dead or dying. It's the lack of oxygen. It's not moving through there, and the blood flow is not supplying life to the area. So now it's starting to die. It could have been minutes, could have been hours. So that's something you got to think about too. So what part of the brain is this affecting? So if it's, let's just say it's the back of the head, we're going to have speech problems. You see right here, it's a complete occlusion of an artery. So now this is dead and dying. So that's where we start to have problems. So your hemorrhagic stroke, and I mean, I think that number is probably a little bit higher these days. It's only 13% of the strokes. We know it's bleeding in the brain. That's something obviously we're not going to see, so we'll go off our assessment to notify if anything's wrong in this person, and we recognize anything different. The way that they answer questions, the way that they get things situated, and that way. People with the highest risk are those who have very high blood pressure, and they may know that they have high blood pressure, but it's untreated. So you may be looking at like 170 over 145. Well, that's really high. Some doctors will say that 150 over 90 is super high, or 110. So the closer those numbers get together, the worse it is. So when you check your blood pressure and you're like, whoa, that's different, that's super high, go back and recheck it. Make sure that you did get the right amount. Make sure you got the right numbers. Did I get everything right? Check it on the other arm. That may be just as important as checking both arms, so you can compare the two. And if one's higher than the other, then you kind of say, okay, well, maybe there's a medium and we can go from there. So hemorrhagic stroke, your aneurysm is a swelling or enlargement of the wall of the artery resulting from the defect or weakening of the arterial wall. So here's that don't look real. I don't know about y'all, but I don't know what this little red spot is or what they're trying to show, because I don't even see anything on my little notes on the side. But I know these are all the vessels. It pushes through there. You can see your valves in here, where it splits off right in this area. So may have to look on that one. We'll get back to that one. Some of the symptoms, again, maybe quick onset, a severe headache. It could be a rapid headache, be like, oh my God, this is pounding. What in the hell is going on? They probably are going to have surgical care for this to fix it, because they may have to put a balloon. They may have to run it up in there. Clot buster. But you can only give that an X amount of hours. Does anybody know how many hours before you can not receive the medicine anymore? I'm gonna let y'all guess real quick. 4. Travis, I know they have gone up to 4 hours. We've always been taught 3 hours. So we want to recognize it, get them to the facility as fast as we can, let the facility know, so the sooner they can get these medicines. It's like the golden hour. Everybody's hearing about the golden hour for trauma. And so you kind of have the stroke golden hour too. No, we're not going to be able to get there as fast as we can get there, but recognizing and get them to the facility so they can get the medication in. And that medicine is amazingly high. It is super high. I thought it was 3. Hold on, Travis, I'm trying to slide it over. I thought it was 3. Was studying with Masters of Medics last night. He said it was 4. And I'm glad you brought that up. So I haven't gone over the edition that you talked about, Master of Medics, but I've heard from multiple people that it is amazing, that they have done a very good with that. So if it's working for you guys, let's use it. I'm hoping I can get onto it and mess with it while I'm home. and get some better ideas, and then I can pull from both of them is what I'm hoping. But that is just my fault. I was not aware of that just yet, and then I saw you post it, so that was my thing. I'm reading something. Longtime Glad stated that the drug should be infused within 3 hours of the first stroke symptoms for certain patients within 4.5 hours. So there's a decent time. So I guess, Travis, both your answers are correct. So 3 hours, and I think the most is 4.5 hours. So what somebody shared with me just a second ago. So thank you so much for sharing that. So your TIAs, your transient ischemic attack, you'll notice it as a TIA. It can last up to 24 hours and may not be able to be differentiate between a stroke or TIA. Every TIA is an emergency because it's still they're showing the warning signs. It may be a stroke that's coming on. They may, like, a TIA is kind of like it's a teaser. It's going to kind of say, oh, look, something's wrong and we need to get you to the hospital. We need to get you to fixed. We notice your body's recognizing that there's a problem and they want to get it fixed as fast as possible. Um, Obviously, if you notice with patients, and all TIA should be evaluated because there ain't much we can do in the field for this. We gonna have to suck it up and deal with it and try to get them as fast as possible to a stroke facility. If you don't have a stroke facility in your area, you have to transport to your most appropriate facility, and you may have to contact air transportation because they're going to need a little bit more. So when the blood flow to the brain is obstructed due to, I'm going to try to pronounce that word, but I think about arteriosclerosis or a small blood clot to the patient may exhibit signs of a stroke. And when a stroke-like symptoms goes away on their own in less than 24 hours, it's been of a TIA. No actual death of tissue occurs with a TIA, but it's a precursor for what's going to happen. If they're having TIA symptoms, something's causing it, and that needs to be fixed. I've seen somebody have the symptoms, they signed the refusal. We went back to them later. We tried to talk them into transport, and they were just very adamant on going on it, and they just wouldn't go. So med control didn't make them go to the hospital, able to get a refusal off med control. That night, their wife woke up to him deceased in the bed. So if you know these things and something is going on, try to recognize it as fast as possible and talk them into the most appropriate facility. Unfortunately, due to time and COVID, that's the world we live in, and that these hospitals are backed up. I know nobody wants to go to the hospital now because they don't want to introduce yourself to some kind of more sickness in their body, but they need to be messed with. They need to be treated on. They need to let the doctor mess with their CT, MRI to check on things, make sure that everything's okay. And if it's not, it's fine. That's what they need to work with, get situated. So try to talk them into the facility. So what's the difference? What is the difference between a ischemic stroke and a hemorrhagic stroke? You're not supposed to see this. When I was making this slide, I couldn't separate the two. So y'all not supposed to look at this. So there is the two different parts that I wanted y'all to put out so y'all would know. So you can see on the bottom is ischemic stroke is caused by a blockage cutting off blood supply. All right, so think about that. So I specifically listed them out that way so you would pick up on it. Hemorrhagic stroke is caused by a bleed in or around the brain. So they're separates. Think about that. I want y'all, I'm trying to keep saying this. Look at these and pay attention to them. A transient stroke or attack or TIA is also known as a mini stroke. So people can have mini strokes forever. People's had them for a long, long time, and that may just be that they've seen a doctor and they treated them and they're on a treatment for the TIA. But these two right here, I'm gonna keep saying that. Bet money y'all probably will see these again. If you do see them and y'all see them on a test, you let me know. I don't know if some of y'all know, I don't have access to your test. I don't see some of your test answers, questions. I don't see none of that. It's a good thing and a bad thing, but it's kind of a happy medium because I try to teach you the best that I can in some of the notes that I've got pulled to the side and on my own homework that I've done for you guys to teach you. So when it's time for a test, I don't know what's out there. So that may be, like I said, it may be a good thing or bad thing. My dad has them. It usually happens while he's sleeping, and we see the after effects when he gets up in the morning. Travis, unfortunately, yeah, you're right, because you don't know everything's fine, going to bed fine, everything's gonna work fine, and then you wake up in the morning and be like, whoa, what, what in the world's going on? Just what he didn't go to bed like this. So yes, I'm aware of that, and again, man, I'm sorry to hear that your dad's going through that. Victoria, I can understand about those questions. I think I've heard that before. Some of those questions make you want to drink a lot. You know, coffee may not be the best thing when you're taking the test. It's up to you on the other parts. 8:55. Okay. So we all know here you're going to see facial droopings. Uh, I'm just going to say yes. Remember, I've been gone for 2 weeks, so yes to that, Victoria. We're going to have alcohol drink some of these questions. So facial drooping, sudden weakness, that their arm or leg is going to drop. We say a drop, which it's not. It's not going to fall off. It's just going to be super heavy. They're not able to control it. And both of them, you may see all the same symptoms, or you may not see them. You may not see but one, and they're all going to be on the same side of the body. So if you have facial drooping and left arm drooping, you know that those are automatically signs, and it could be right side. It just affects people different, depends on what side of the brain is being affected. uh, there you go, ataxia, or the loss of balance. They can't, every time they stand up they fall. That's the reason why a lot of times you may get called to an elderly facility or a residence to where they've fallen multiple times. Well, there's a reason why they're falling, and it's not just they old. I hope to get to that point, but this, they may have other things going on in their brain that's causing them to lose the balance, or they, and it could be their inner ears. I mean, there's so many things that we have to just do a very good assessment on. If you ask the care provider that's in the facility or in a retirement home, how long has this been going on? Well, they started having a lot of issues the past 2 days. Well, you should have called me on day one because that could have helped. But this may be something that's a permanent thing that you're not going to be able to fix because they've waited so long. So those are some of the symptoms of a stroke. Those right there, you're probably going to see them again on some of your questions. I bet you. Again, I don't know, but I bet you. You may have some vision issues, also, and some headaches too. That you may have vision issues. It could affect one side, one eye or both eye. Blood pressure is another thing. They may have blurred vision. So if they have high blood pressure with blurred vision, you could be looking at a stroke. You may just not see it because you're concentrating on that high ass number of a blood pressure, and you're like, oh god, that's super high. Well, they may be having a stroke. Blurred vision, double vision, and there's a difference. You see like two pins versus blurred, and you just see like, well, I think something's yellow there. I'm not real sure. I haven't ever come across the difficulty swallowing, but I know that a lot of them will talk about the dry mouth. Um, they will swallow, but there's nothing there to swallow. So that may be because they're trying to breathe in and out of their mouth. So think about those things. Speech disorders, we know that's there. Bear with these people. Don't giggle, laugh, cut up, because they know in their brain what they need to say, and they can't say it. So that's where your speech disorder comes from. Um, so if they do say Wednesday and they're asking what color shirt do you got on, just move on. They'll try to harp back. They'll try to harp back over. Wednesday, Wednesday, because that's all that their brain is telling them to do. So they're like, yeah, yeah, it's okay. We'll move right along and ask another question to where you can kind of get their attention on that. Uh, Aphasia is the difficulty expressing thoughts or inability the right words. Mary, can having a stroke make a person behavior change? Yes. So we talked about that. And Robin, vocabulary is limited. Yeah, yeah, yeah. Right. It's actually what we're talking about now. Good deal. So some of the people that if you see that's answering, you also probably have had these happen in the family or deal with this. They can make them regress into age-wise or can make them very angry. It's just like they tried to do a Control Alt Delete reset on the brain, but they maybe only got like Control Alt 9 and they never got to delete. Robin, you says your husband has had 3 combative unknown some to bite. Yeah, be very careful. Like I said, we talked before, don't put your fingers in nothing nobody's mouth. They having trouble breathing. That's what we have. All these cool little tools, toys, bite blocks, oral airways. We can do those things. They can get mean. They can look at you out of nowhere and spit on you. Their entire thought process, the way that they process things, is just not there. So that's the reason why that they get like that. We spoke a minute ago on the dizziness, confusion. Y'all are all answering it right on the side of the question, so I feel like we just resort back to your questions and your answers. That I think this is the engagement that I would like to see you guys on some of the Facebook questions we ask. Is not only just asking the questions for you guys to answer, but when we ask another sub question for y'all to kind of debate back and forth. I know Rob and I have kind of poked at each other on the side on our texting about these things and how good we like to see you guys engage, but we don't see everybody answering the questions. And I know that it's not required, but I'm still going to poke at y'all about that. All right, so got about 10 more minutes. I'm going to give you a break. We see that right there. Coma, tongue deviation, restlessness, combativeness, weakness. I think we just covered those. Like we just said, Robin and Mary, y'all answered these questions for everybody in the group. And Travis, you've said the same thing about about your dad, about what they went to bed with. They wake up the next morning and something completely different. So it's like you guys have a very decent knowledge of what's going on, and we may not have realized, but like, wow, I've seen those signs and symptoms before. I just didn't know what they were, or you've had to deal with it on a personal level. So your knowledge is a lot better on some of these questions and tests and all that than you see. So when you go to take these questions and tests, try not to think on the personal level for a little bit. Think on the test side. I wish I could tell you how these are going to be written to get you on a better thought process, but I'm not real sure. So I'm just super stoked that y'all are, typing back away on these questions here. So on the left hemisphere, the stroke in the left cerebral hemisphere causes aphasia, inability to produce or understand speech. Speech problems can be very, very widely. They can not speak at all. They can move their mouth. They can try to because they're not able to. We're just not being like, I'm sorry, you need to open your mouth and talk to me when you talk. That's not what we need to say. We need to recognize that there's a problem. Let's try our best to fix the problem and transport it most appropriately. Stroke may also cause paralysis of the right side of the body. And somebody tell me, but why this is happening on the left, but we're seeing it on the right? Does anybody know why?
Because the brain works, the left side of the brain works the right side of the body. The right side of the brain works the left side, works opposite.
Right. When I ask these questions, I'm going to start playing the Jeopardy music. I got to Google it. I got to YouTube that. That's what I feel like I'm sitting here waiting. Or, back in the old movies when you ask a question, they're like, Bueller. I'm sorry. That's just my brain. Every time I ask that, I'm like, oh, one of these are going to want to work. Oh, Victoria, you didn't Google it? Oh, go girl. All right. So on the right side, so you're going to see paralysis, numbness, deficiencies on the left side of the whole body. It's the same thing that you're going to see on the right side. It's just now you know what side of the brain potentially is affected. It's going to possibly be a lot worse if there's traumatic injuries. The coup contra coup effect from being in a wreck, you may not recognize it right this second. You may get it 12, 13 hours plus, or could be up to 48 hours. That's the reason why we always tell the people when they get in a wreck, if you have any blurred vision, nauseousness, or vomiting, please call us back. Any kind of blurred vision, because that is a sign of a bleed. They may start to have issues. We talked their words may be slurred, so they're slurred, like they sound like they've been drinking, maybe like when the cop pulls somebody over and they think that they're intoxicated, maybe because they're putting off the fruity smell of their diabetic problems, that turns into an issue because they didn't fix it when they transported them and they died in the, in the lockup. So those are the things. It helps to have a knowledge of it all and things that can happen. So if you think that they're just, oh no, he's drunk, don't worry about it. Well, he may not be. He may just be having a stroke, and you're not recognizing it because you're just assuming. Because we went to this guy 5,000 times this past month for being an alcoholic. Well, dig a little bit. It's not hurt. It's not gonna hurt you. Dig a little bit. It's our job. See what's going on. Let's see. Neglect and lack of pain cause many patients to delay seeking help because they're used to it. That's the thing, is it happens. They may have happened slowly. They may have that TIA slowly happen over the past couple of weeks and even to a month, and they're like, oh, it's normal. They've kind of dealt with it and lived with it. No, it's important. There's a reason why you called us here. Something's going on. Let's address that and get that fixed. Make their emergency important to us. So bleeding in the brain, patients with high blood pressures, they may cause the bleeding, may cause by as a compensation response. Increasing blood pressure is signs of could be high bleeding. Significant drops in blood pressure may occur as the patient's condition's worse. So I'm trying to remember what it's the cushioning effect. Sorry, my wife just walked outside and walked right back in with food. I didn't even know. I was like, well, she didn't leave. Kind of got me there. So you monitor the blood pressure for changes, and anytime that you suspect a TIA, stroke, traumatic injuries, how long are we going to start assessing their vitals in? What's the time frame we're looking at? Good job. So it's a critical patient. We're going to treat them as critical. We're going to do an assessment on them, continue that assessment every 5 minutes. And it's going to be a lot of stuff to do. So when you do that, you're thinking, oh my God, I'm doing it like every 3 seconds. And when you do it, it's ultimately, you should got to sometimes you can set your monitor to go off every 5 minutes, and you realize how fast that is. But when you time to write your report, you've got all your documentation, all your information that's needed because you thought about it on the front side is to get everything going. What time is it? 7:06. Tell you what, I'll give y'all a few extra minutes because I'm thirsty and I didn't prepare with water and I was already running behind, so I was trying to rush. Let's take. I'll see you guys at 7:15. How about that? 7:15. I'm gonna put it in here. 7:15. Return to class. How about that? All right. Anybody got any questions so far? I know it's a lot. I feel like I'm rambling because I'm trying to do multiple things because I didn't prepare. See you at 7:15. All right, I'm back. I know y'all are upset about that. I'll read y'all some information that I always like going to the Mayo Clinic for information on things. It says a stroke occurs when the blood supply to the part of your brain is interrupted or reduced, preventing brain tissues from getting oxygen and nutrients. Brain cells begin to die within minutes, like we've discussed. A stroke is a medical emergency, and prompt treatment is crucial. Early action can reduce brain damage or any other complications. The good news is that many fewer Americans die of a stroke now than in the past because we know what we recognize. We have the stroke programs, we have the stroke foundations. CDC pushes out a big thing about strokes. Some of the symptoms we're going to look at is if someone that you're with or maybe having a stroke, pay particular attention to the time the symptoms begin. That's very important to note when we transporting these patients to the facility. Is how long has it been going on? When did this start? Why are we just now getting here? Things like that. Trouble speaking and understanding what others are saying. You may experience confusion, slur your words, or have difficulty understanding the speech. Paralysis or numbness to the face, arm, or leg. Problems seeing in one or both eyes. Headaches, trouble walking. And it says, ask on here, it says, like, when to see a doctor. You seek immediate medical attention. Think fast. They're promoting, that's the new acronym for recognizing a stroke, is FAST. So it'll be the face, ask the person to smile, and does one side droop. Arms, ask the person to raise both arms. Do one arm drift downwards, or is one arm unable to rise? Speech, ask the person to repeat a simple phrase. Is his or her speech slurred or strange? Don't use like the one is like, don't teach old dog new tricks. There's simpler ones that you can say out there that's not confusing to them. And then time. If you observe any of these signs, call 911. So that would be us. So that's why we're there. But to recognize these things, you can say time, as in, when did you see these signs first? When did we notice them? And that's why we're here. So FAST is the acronym I think they're pushing out to the public. I know I've heard it a lot of times on the radio. Like the guy saying, I think I'm having a stroke. Oh, you're not going to talk to me when I come in the door? So the guy's talking to himself and is promoting the acronym of FAST. Just a little side note. All right. Conditions that may mimic strokes. We talked about hypoglycemia a while ago, where we talked about maybe the alcohol that got them. So we talk about postictal. I'm sure some of you guys have already seen this in some of the ones that y'all were talking about, but it's a period following a seizure that lasts between 5 and 30 minutes. It's kind of like their space out phase. The ones that have, a few of y'all that have been through this, have y'all noticed anything besides a postictal state or any signs that you recognize some of your families had that? If y'all will chime in, that'd be very helpful. So, so it's characterized by labored respirations and some degree of an altered mental status. So they're going to be sleepy, specifically when they have a seizure, but these people are going to just be real kind of lazy. Victoria, sometimes in a stroke, they will urinate on themselves, a lot of times in seizures for sure. If it's subdural or epidural, bleeding is near the skull, presses against the brain. That's where we're talking about the pressure. So if they start having these pressures, these headaches, these rapid onset of headaches, that may be because of the bleed and its location. If it's pushing in one part of the brain, it may feel like, oh, my right behind my ear is what's really hurting, when the bleed may be from the left side, and it's affecting the right side like we spoke about. So consider its location. So my son sleeps from a long time and doesn't remember anything. I'm sorry, man. I know I keep saying I'm sorry to hear that. It's I know there's so many treatments out there now, and it's trying to figure out how hard to work on these and which one to go in when you start having to deal with your family members and all that. So I wish you the best on that, Robin. I hope everything gets better and over time maybe potentially grows out of that. So here's some pictures on the bleed right here, the subdural. Gotta move my screen on this side. And then you see the dura right here where it's a little bit higher. And then the dura is affected here in the subdural hematoma. You see why it's affecting different areas because of the way it pushes. So if you look, here is the dura and the fracture line, the medial magneto artery. So it just gives you ideas and pictures on what can potentially cause these mini strokes. I don't know why my screen keeps popping up at the bottom. Probably user error. So I'm a picture guy. That's why I like these to show in here. I see the pictures. I kind of understand a little bit better some of the areas that may be affecting. So I'm glad that they enter these pictures in here. So now seizures. I'm sure that a lot of us deal with these, have dealt with these maybe personally, like we've been talking through the whole class. Some of their families. So a seizure is a neurologic episode caused by a surge of electrical activity in the brain. Not saying that they got electrocuted, or it's just an uncontrolled surge. They sometimes they don't know why it happens in people. Other times they can narrow it down to certain things cause seizures. Can happen from a traumatic event. Can happen from a fall, strike to the head. Could be born like that. So that's something to think about. And it's like, hey, what causes this? We don't know. So it can take a form of a convulsion and or be associated with temporary altered in consciousness. Victoria, you're saying epileptic seizure. Which one are you referring to? You kind of confused me on that. I was trying to look at something else too. Um, so you'll have two of them: is generalized and partial, partial focal. Um, that's how they brace the two seizures down into on what category they are. I'm trying to look up something that I read the other day that I wanted to bring.
What I was asking was, isn't epileptic seizure, isn't that a kind also that's caused by lights and flashing lights and stuff?
Correct, and that's the reason why, like, if you know you're going to a seizure, turn your lights off, uh, because the flashing of the strobes can cause those, and they can trigger them. They, I'm trying to type in seizure, and I put the abbreviation for it in my computer, and it was like schizophrenia, and so I'm gonna try to correct the make sure that's right. So where's it at? Where's it at? Where's that? So in your generalized seizures affects both sides of the brain. You have your absence seizure, and this may be in later on, but I read this other day. I really liked it. So sometimes called petit mal seizures, can also be rapid blinking for a few seconds, or you're staring off into space, like I was talking to y'all about a while ago. Y'all are probably familiar with a lot of these. You have your tonic-clonic seizures, or also called your grand mal seizures, and they can make a person cry out loud, they lose consciousness, fall to the ground, and that's where your jerking comes from, or your convulsions is in your tonic-clonic. Then you talk about your focal seizures. You'll have your simple focal seizures, is affect a small part of the brain. These seizures can cause twitching or change in sensations, such as a strange taste or odor. A complex focal seizure can make a person with epilepsy confused or dazed. This person will be unable to respond to questions or direction for up to a few minutes. And then you have your secondary generalized seizure. Begin as one part of the brain, but then spreads to both sides of the brain. So, in other words, the person first has a focal seizure followed by a generalized seizure, which may last several minutes in those. So it broke it down. The reason why I want to point that out is because we talked about the generalized here, and then we went to the partial, which is focal. But they do have multiple subclasses in there, and that's the reason why when I saw that the other day, I was like, oh, I needed to keep that because I liked it. Gave me a little bit of better idea of what types of seizures they are, not just saying, oh, you got generalized or partial. Well, everybody's heard of the tonic-clonic or the grand mal seizures. So now you know what classification that they're put in. It's either generalized or partial. Oh, look, we just talked about that. Told you. May go over that a little bit later. So it does not involve any changes in the motor activity. It says it's right here. It's a brief lapse of consciousness. They may have it for a couple of minutes and right back out of it. They should turn around and have the full body twitching, and then they may fall, have the muscle jerks or the body spasms. I know we talked about that when I just read it. So the partials here, we went over that one. Having some twitching, a brief paralysis. So when you get further into the complex, you're going to look for these are going to trigger more of your altered mental states. So the strange taste, so they taste like, oh, that's bad, or you're going to notice like that where they smack their lips. I see that a lot in like your geriatrics and your nursing homes. That's just part of it, and it's not saying that they may constantly have that type of seizure, and that's what you're going to look for. So if you go to your next nursing home to pick up your dialysis patient or the hip fracture that fell out of bed that was in the bed for the last 7 hours, one of those weird ones. Look at you go down the hall. Look at the young ladies and the older men that are sitting there that smack their lips. You'll see it, and you'll be like, oh, that's a type of seizure. And ask, be like, hey, just a quick question. Does this lady have a seizures by any chance? Then the number one answer you're going to get, it's not my patient. Well, I think every nurse in the nursing home doesn't have a patient because they all say it's not my patient. And I'm sure you guys have been on the ambulance, know what I'm talking about if you've been to at least one nursing home in your life. So AURA is the patients may experience AURA prior to seizures, and it can include visual changes or hallucinations. So it's where we talk about when somebody was talking about the change of attitude. So it's right in here. People with a history of seizures recognize their AURAs and usually take steps to minimize it. And that's where we get the dogs and the animals. They have these seizure dogs that kind of start pushing them to take a seat or lay down because they smell it. They have the ability to recognize it, maybe the change of the way that the person is, and they check these and they realize it way before it all comes out. Not every one of them that has a seizure will experience it, but I'm trying to figure out. Most of the ones that I know now have animals. They have their seizure dog, and they go everywhere in the world with them, and they recognize them. I've only seen one dog, multiple dogs, obviously I've seen, but only one actually pushed the patient to sit down, and they're like, "Hey, listen, you may recognize this in a couple of minutes. I may have a seizure. Please don't freak out. My dog will be on me. They'll start licking my face when I need to come back around. Just make sure I don't hurt myself." And you're like, okay, it's my job. But then the dog takes over, which is really neat to see, and it works out really cool. So your generalized seizures, characterized by sudden loss of consciousness, chaotic muscle movements. We see these when somebody says they had a seizure. This is what we're thinking about. Oh, they were jerking. Oh, you got to be careful. They're gonna bite their tongue off. Well, yes, they can, but that's where everybody sees this. So right here, characterized by a cycle of muscle rigidity, relaxation, usually lasting 1 to 3 minutes. And you got to think how much their body is firing. All the electrical impulses are coming through their body at one time. That's what makes them very, very tired. And I'm sorry, I just went blank. So Robin even stated here that their kid didn't remember anything, and that's common because their body they used up all the stored energy, the all stored sugar. And when they finally do come around, they do get a little hungry. And they're like, man, what's wrong? What's going on? Why am I like this? It's because you had a seizure. You don't remember? No, I didn't have a seizure. It's their body, because their brain is just firing, just nonstop, and everything's hitting, but it's not recognizing what's going on. So that's why that they're super tired. Some that last longer than 1 to 3 minutes most people have them, They can treat them at home. Family can. But if they last longer than 3 minutes, that's the ones that are serious. Something else is going on. I mean, don't get me wrong. Every seizure is serious, but the ones that are treated that last longer than 3 minutes is what I meant to say, are the ones that you're like, oh well, this is not normal. We need to act on this. Let's move. Let's get them to the hospital. We help us out. Um, so you're going to see tachycardia, obviously the hyperventilation because their body's jerking and moving and just it's like a huge workout of every single muscle in their body, even down to their toes. So everything's worked out. Um, you see right there, it says most seizures last 3 to 5 minutes. The postictal state's going to follow that. I've seen it last up to an hour. Um, Over time, they start to get everything back and going. They come around, they'll talk to you, then they'll look around and be like, "Oh my God, did I just have a seizure?" And then they start to freak out, or "Did I hurt you when I see?" So they didn't realize what was going on, and now they're coming around back into civilization, and they're like, "Oh God, I'm nervous. Maybe I did just urinate on myself." And then you got to think, is this poor kid in school? And now you got to protect them from that, being seen as you take them out. So think about that on your location and who you're taking care of. So those are big things that we want to look for. Just if they go over this and people are calling you and they said they've had multiple seizures in the last 5 minutes, or this is seizure 26 and they've all lasted 7 minutes apiece. Well, that's kind of important. Let's uh let's get somebody to fix that and get them to a hospital. So your absence seizure. So we used to call them petit mal seizures. That's what we all used to know, and they're seconds at a time. And it says right here, patient recovers with a brief lapse of memory. We've all had that. I can tell you, I drive a lot to and from work, like I've told you guys. There's sometimes I'm like, how did I get here? Oh God, what did I miss? Uh oh. And then you sit there and you're like, what did wow, I didn't even know what was going on. What happened here? You didn't black out. You just had a petit mal seizure. Robin, he also has the red spots on his face, around his eyes, looks almost like blisters. Robin, is that something that's always been there, or is that something that's come up here recently from, the
He normally gets it after he have like a long seizure, like the ones that may last from 20 minutes to an hour. You could tell that he had like a really workout, like he's trying to come out of it and he couldn't come out of it, and
yeah,
he's fighting with his,
gets those red
and
spots
that's
because he's super hot and
yeah, he get like
worked out?
little face blue.
Did you notice any spike in temperature when they're doing that?
No, but he does have the headaches before.
Hmm.
And it's either something that happened at school that triggered it, because he has autism as well. Either something at school triggered it, or if he was on the computer for a long period of time staring at that screen, that could trigger it. Or if the seasons change, that triggered. He has several triggers that would make him go into a seizure.
Robin, does he wear glasses?
Yes, he does.
Does the glasses at the same time have the blue light blocker in it?
No, he don't have those.
Well, I don't. I'm gonna say this really quietly because my wife's listening. I'm supposed to wear glasses as I drive and function throughout the day. I don't. I only wear them when I drive. But I've got a hold of these blue light lens glasses, and man, they have helped me. Like, 'cause I look at a screen a lot when I'm at work, and like right now, I have
Uh-huh.
a computer, and then I have my tablet to the side. The blue light, they can add that into his glasses currently, or the next time it's up to get him a new prescription, and that will also help him on staring at the computer, that your eyes don't get so tired. So maybe something small to look at the next time y'all go to do glasses.
I'm gonna have to check into that. Even sometime when he's outside in the sun, he'd have to go back in because his body's getting overheated,
Mm-hmm.
or the sun is like making his skin burn. Next thing you know, he just breaks out into a seizure.
Whew, baby, I'm sorry for you. I hate to hear all that. I know it's a working process, but I hope Tom helps him out and he grows out. How old is he?
He's gonna be 17 next month.
Oh, got you a big baby, huh?
Yeah, he actually gets embarrassed when it happens at school, because
I
he
bet.
didn't want everybody to know at school that he had seizures, and it happened several times in class. And when it happens, he wants to put his little hood on his head and keep his head down because he don't want nobody to see him.
Well, and kids are mean. I mean, I pick on my babies all the time, and I'll just say, look, if you can deal what I deal with you, kids these days are just mean. I mean, I know we were mean in our age too, but and the older we get, and then we see the way the world is. People are mean. So I'm sorry he's going through that. I hope over time something happens in the future, and they're able to fix these things, and they can figure out what's going on with them. So
Right.
I wish you the best, baby.
Thank you.
Thank you for letting us know on the information. See, that to me is more beneficial to sitting here and going over these slides or thing that I see on the side. So I hope that helps you guys understand some things out from the stuff that Robin and her child has to deal with. So status epilepticus is a seizure lasting more than 5 minutes. So that's where it becomes a more serious, and it's more injury related. We want to worry about these, and we can tell the facility, look, these lasted X amount of time long. If it lasts longer than 30 minutes, they say hold on, right here, it's referred to as status epilepticus. Just know that those are dangerous and they last longer than 5 minutes. Anything after that is critical, but they did change the name on it, so that's probably going to be a test question right there. Is what is the phase of status epilepticus, or after a seizure lasts for so long, what is it called? So keep that in mind. So in your book on 17.2, it talks about the different types of seizures. If it's congenital, tumor related, hypoxia. So you have your epileptic, structural, metabolic, and febrile. We all hear about the febrile and the high temps of children. We know in some cases due to COVID, we always say that's the big thing we talk about right now. Everything's COVID related. Is the high fever that some people, if it gets over 103 or 104, that can cause brain damage. Yes, some of us grown adults still have that brain damage, and it's not because of fever. No, but here's a little chart. It's kind of cool, nice to have around. Gives you ideas. I'm pretty sure you might want to refer back to that if you happen to be doing a test. They may be say what cause of a seizure versus what type. So there's some other causes of seizure, some medications that control it. We all probably know it by these names are here in the parentheses, unless you know the given name like phenobarbital. Your Dilantin's the biggest. Topamax. I took Topamax back in the day for migraines, and I took a very low dose. And let me tell you, it affected my eyes, my memory. I think it's a long-term effect, is kind of what my wife says, but but I'm not a fan of Topamax, but it does its job. In high doses, it'll treat seizures. So Dilantin, Keppra, Depakote, and Topamax are kind of your biggest ones. I have obviously seen them all. Phenobarbital is one of your biggest names out there. So there's a ton of different names out there for seizure medication. So this is just a few of your common ones. Let's see. A seizure may be caused by an abnormal area in the brain, structural cause such as cancerous tumors. We all unfortunately know about that. You may have meningitis, scar tissue of some type of injury. If, let's say, that's the reason why they're so big now on the concussion program in the NFL, is because of long-term effects. Boxers are the same way. Like Muhammad Ali, in my opinion, one of the best boxers for as long as I've been alive. He started having TBIs, the seizures, because of the consistency of being hit in the head. So that's going to cause scar tissue. And then, poor man, I don't know how long he lived for, but he was phenomenal. And he was able to function. He just couldn't speak to everybody. And that's some of the results of head trauma, continuous head trauma. Some other causes, drug overdoses. So if you can have like DTs from to alcohol use, a lot of times I've seen them treat alcohol abuse with DTs with alcohol. If they are on seizure medications and they stop it. They just completely withdraw it. Unfortunately, these days it may be because of high cost. A lot of these medications aren't cheap, but if they stop it because it's either eat or get my medicine, well, a lot of people are going to eat. I mean, I know their medicine makes them feel better, but they cut off for the medications. We talked about the high fever, poisons, drug overdoses. Man, that is there's. I'm sorry. Hang on one second, guys. I apologize. I had to correct the dog real quick. Um, so all these signs and symptoms and all these fun things can give us tales of our assessment. That's why we've preached and preached and preached of doing a very good assessment, a history taken. Because sometimes if you just don't ask that family member, do they have a history of, or even the care provider, they just gonna be rude and just not tell you because you didn't ask. If you wanted to know, you should ask for it. So if you know that they've had a recent, you go to a rehab or something, and they start having these seizures, maybe it is because of the drug overdose. Victoria says, my fiance is a recovering alcoholic, and his BAC would get so high, he would go into a bad seizure and end up in ICU, and they had to treat his DTs by giving him alcohol. Correct. That's wonderful news. I'm proud for him. He's been sober for 3 years. I think that's great. I wish him the best of everything. And this is one of the ones, and I'll use him for example, that could teach you a lot about alcoholism and what it does to the body, how it affects the brain. And if somebody's open to talk to you like that, let them teach you. Like I've told y'all about, the best thing I've ever learned is from an 8-year-old with diabetes. He taught me more than 20 years of being a paramedic, and I'll never forget all the stuff he said. So listen to your patient if they talk to you and tell you, hey, this is what's going to happen. Da, 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 da. Well, how do you know? Because I've been through this the last 10 times, unfortunately, because of this. Okay, well, what else can you tell me? So that helps you learn. And it's just those abilities. Just listen to your people, listen to your patients, talk their lingo if you have to. What's the time? All right. So the importance of recognizing these seizures, because it's our job to treat these people. It's our job to take care of them. It's our job to take them to the most appropriate facility. If they turn cyanotic like they just said, that's your fault for not fixing it. Provide them some oxygen. Seizures may be prevalent in patients from breathing normal. And a patient with diabetes, the blood glucose level may decrease. Check a CBG. That's easy. If your protocol allows it, right there, so I didn't even see that. Monitor your blood glucose level for a patient with diabetes as a seizure. I was burned one time, and I'll never forget it. A very good friend of mine, Dr. Andy Anderson, up here at the Jackson Medical Center. He is a phenomenal. He was a paramedic first, went to med school. I brought a guy in, and he was seizing, and I fixed his seizure, sedated him, got him situated, tubed him because he quit breathing because I gave him so much sedation. And we get to the hospital, and he's like, "Hey, what's his sugar?" Couldn't answer him. Checked the sugar, and it was like 4. Well, if I'd have fixed that, he wouldn't have had to been sedated and then had a tube down his throat. So he kind of looked at me and was like, "Good job, medic." And it was like that hard lesson that I learned in front of everybody. I kind of embarrassed myself because I try to take myself to the higher level and learn these things. And I reacted to the surroundings and the situation versus reacting to my patient. So now I don't really care if you come to me with a stumped toe. Hey, let's check his sugar. I'm just gonna do it. Everybody knows on the platform, if they come and see me, I'm checking the sugar. Period. They gonna walk around with a band-aid on the finger because I poked them. That is just what it's gonna happen. You get burned one time, and you won't forget it. Dr. Anderson is one of the best doctors, in my personal opinion, in the state of Mississippi. So you'll learn over time. If you get burnt, you won't happen again. So look for some other problems associated with the seizure. What is the potential cause? Did this person uh, maybe they have inner ear problems, and that's what's creating the balance problem. So now that they're tripping and falling everywhere, we'll pick these things up. If they have a head injury, were they recently involved in a motor vehicle collision, ATV wreck, anything that could potentially have caused a traumatic head injury, a hard, heavy dropped object to the head, those can do it. That's the reason why sometimes that they'll say monitor, don't let them go to sleep for a couple hours. Now they're obviously now with concussions, they've changed the concussion protocols. If somebody is sleepy, they'll let them go to sleep, but they'll wake them up every 30 minutes, every 45 to an hour. They let them sleep up to an hour. I know that they've changed the protocol and the assessment procedures for concussions, but that's the reason what they don't want them to go into having a seizure. And that could be a result of a bleed or an imbalance issue. Could be their sugar's low because your paramedic forgot to check it. Hint, hint, don't forget to check it. So your postictal state is after a seizure, the muscles relax, they become flaccid, and the breathing becomes labored because they're tired. They just got finished with the most intense workout that they've ever had. And this thing, they could have these seizures, oh, what did you say, Robin? Sometimes lasting up to 30 minutes to an hour. I think that's what I heard you say. So think about
Yeah.
how tired this person's going to be. I mean, your child's probably wore out by the time that they have the seizures that last that long. You're going to have to give that baby some time to sleep. Watch them. Now, I'm sure as a parent and as a child of any age, they start seizing, you're going to be like watching them like a hawk. You can't go to your room and go to sleep. You can lay right here on the couch because you want to keep an eye on them. You want to make sure that they continue to breathe and that everything starts coming back, that their breathing starts to do, okay, how many times a minute are they breathing? Because I know y'all do it. Y'all don't do it now. When you look at your next seizure patient, you'll be like, oh, that's breathing 24 times a minute. That's not right. We need to bag them. Just give them a minute. Still provide them that oxygen, but they're not breathing correctly. They're not breathing sufficiently enough. So when they finally start breathing, they're going to have slow, labored breathing. Work with your patient. We're not going to see their liver functions because I don't expect you guys to collect a urine sample and test it. It's probably not in your protocols to do that. So just remember that. But in the back of your mind, think of their liver functions. Because of what their body just went through is going to affect their liver output. And it may be characterized by hemorrhagic, resembling a stroke because of what's affected, because they're hypoxic. They're not getting enough oxygen. The blood flow may be altered because of the seizure that they just had. So you may be like, oh, is he having a seizure? Oh, well, now he's not answering the questions right. I don't know what to do with my hands. So you're going to just take a deep breath, relax, and breathe. And you got this. You can do it. It's most commonly characterized by the lethargy and confusion. The patients will become combative. I'm not going to say everyone will, but they will come combative. They are as strong as an ox. The worst time I ever got my butt beat was by a 75-year-old preacher that had a seizure the very first time, and all of us were standing there just, oh my God, okay, let's go with this again. He kicked our butts, and there was 3 grown ass men that we were just like, this is not cool. Whoa, come to find out, his sugar got super low. He had a seizure. Well, when we got all that fixed, he was like, what y'all looking at? Uh-oh. Did I have a seizure and fight y'all? They don't know these things. So you just gotta, sometimes you may just have to be very, protect yourself because of their combativeness and treat them when they go into postictal state. That may be your only time that you can treat them or grab them and move them. And again, right here, consider hypoglycemia or potential infection. We're not gonna be able to check their WBC out there on scene, but we can check this right here. Go for your hypoglycemia. What time is it? Somebody tell me what time it is? We still got 10 minutes. All right. So seizures are often mistaken for syncope or they're fading because they're gonna fall. They're not gonna be able to hold their balance and have a seizure standing up. It's just not going to work. Their body tightens up, locks up, and it's because all the neurons and everything's firing at once, and it's just like an electrical impulse that's passing through their body. So their balance is not going to work. Seizures may occur in any position. We want them to lay down. We want them to get comfortable. We want to protect their head. They can seize on a hard floor, but let's protect their head. Let's put something underneath there, like your purse or, I'm sorry, Victoria, I just saw your message. Me and J Payne got our butts whooped by a nursing home. Yeah, by a 95-pound lady. Man, I'm going to tell you, they're oxes. Woo! They just don't realize how strong they are, and you're on the receiving end. So think about that. If they faint and they're breathing normally, they're able to do things differently associated with postictal state, like we spoke about, signs and symptoms of the stroke. Of a seizure. Don't mistake them just because they fainted as having a seizure. It's important to keep in the back of your mind, just because now we're going to go over seizures, and you think now when you see somebody like, oh, they're having a seizure. Well, no, they may have fainted due to stress or a stressful situation, or they just having a respiratory problem and they're hypoxic. So gotta think, gotta do the whole assessment. What have I found? What do I see? BSI seems safe. What does dispatch tell you? What did the bystanders tell you? And all this is going through your head, and you're like, y'all know what I'm talking about. I promise you, it'll hit you. So some other altered mental states aside from a stroke, you may have drug-related, a TBI. You may have hypoglycemia, alcoholism. We talked about all those things to begin with, that are different from strokes and seizures, but they're classified in the same because it all affects the brain, so it all falls under neurologic. If a patient is not thinking clearly or incapable to be aroused, you can try your painful stimulus. If that doesn't affect it, it could be caused because they've OD'd on medication or they've had an exposure to something. So there's different reasons and different abilities and different things that are going to cause them to have altered mental status. Maybe an altercation where they got knocked out and then they fell and hit the ground can create a bleed. So when they start coming around, they're confused. They're very lethargic. I don't know what's going on. Confusion. Sorry, I was laughing at my wife. In some cases, the patients will be unconscious and the patients may be alert but confused. Like we just went over and just said that. Causes of AMS, hypoglycemia. Patients can have signs and symptoms that mimic strokes and seizures. We've gone over that we're always going to check their sugar, just in case. A patient who's had a stroke may be alert and attempting to communicate, but they're not speaking. They may be not saying they're nonverbal, but they just don't make any sense. They may tell you one or two words, or they may point at something and look at you like they're trying to look through you because they just don't know. A patient with hypoglycemia almost always has an altered or decreased LOC because that's their energy. That's their gas for their body. Well, now it's low, and they not functioning. They're not firing on all 8 cylinders. If y'all know what I'm talking about, they need some help. They need some gas in their tank, and it's because they got that low sugar. In some areas, you got to tell them you got that low blood or high blood. That's just because of the area that you go to. That's what they know. It's what they've been told their whole time. You got that low blood. Well, that's what makes you go into hypoglycemia. You get confused. Well, why is he sitting on the porch and it's 900-degree weather in Mississippi when everything's hot and he just don't look right? He's covered in water. Well, he's probably had a stroke or a seizure, or his sugar got super low because he couldn't afford it. Patients commonly take medications that lower their blood glucose. Patients can also experience seizures, like we said, when it gets to a certain level. Mental status is not likely to improve within several minutes. Even once the ALS provider starts an IV, they either give them D5W or they give them D50. It's going to take a minute or two. Once that medication gets into their body, you need to encourage them to eat like normal human people food, not fast food, not heated from the freezer, like a good, I always try to tell the family, a good old home cooked meal. They need that peas, they need the natural sugars, the natural energy that gets out there. You don't need to get them to drink, oh, just give me an energy drink. No, you need to drink like that good old food with some water to get your sugar back up. Because it's gonna drop again if once I give you this medicine and you don't do anything, it's going to drop again and potentially can be a little bit lower. We've gone over this right here. You considered if they've been involved in a motor vehicle collision. It doesn't hurt to poke their finger. It takes, I think, what's the machine count, 5 seconds, and you got a result. So always check that sugar. Be in a habit of checking the sugar. On all my sheets that we do a patient, I mean, it's kind of their demographics, our demographic sheets. It has it listed. What's their CBG? Well, there's a reason why we want to know it is because it could be a potential underlying issue. So get it early and get it written down, and you don't have to worry about it but one time. So you don't have to do it every 5 minutes. Delirium, it's not a symptom or a disease. It could be a new complaint from infection. Because their medications are changing, they're trying to figure out what's going on. You can reverse it when it comes to with treatment, but you got to kind of, it takes a little bit of a, you walk into a hospital and you tell a doc they got delirium, they're going to look at you like, wait a minute, what you trying to tell me to do? It's very hard. It's a rapid onset. They're confused. It's usually caused by withdrawal from alcohol. So it occurs within a couple of 3 days. It lasts for maybe 3 to 6 days. I've seen it last for up to 7 to 10. And the physical effects are going to be shaking. You're going through DTS. Basically, is the easiest way to put it. Let's see some signs of delirium. Your symptoms are going to be body tremors, change in mental function, agitation and irritability, deep sleep that may last for a day or longer. Man, I think I need some deep sleep to last that long. I just can't do it. My body hurts. My back hurts too long. They could see some excitement or fear. They could see things, start having hallucinations, and then bam, they're full, like they're going 110 miles an hour. That burst of energy because they got 12 hours of sleep or more than 1 or 2 hours here and there. So those are some of the signs and symptoms that you'll see. Well, we just said it, so I don't have to read you that one. We'll cover this last side and we'll take a break, and I'll give y'all a break from having to hear me. Let's see. We just went over those. I'll go ahead and give you a break. We'll see y'all back at, what is this, 8 o'clock, 10 after 8. Anybody have any questions so far? Any want to knows, any learns? I can pick up something while we're taking a break real quick to teach y'all. If you don't, I will see you in 10 minutes, or I'll see you at 8:10. Thank y'all. See you in a minute. All right, let's get this back going. I don't know if you're all like me, but I'm starving, and hopefully y'all can eat while I'm going over this boring stuff for you guys. All right, so again, we'll go back over this like every single chapter. So our scene size up is going to start as soon as the dispatcher goes on there. So if a patient has AMS, they may exhibit with a lot of signs, symptoms, and behaviors. Let that be triggers. Let that kind of tell you if they say a subject's in Walmart parking lot acting erratic, PD's en route. Well, it could be numerous things, but let that start your motor thinking on what you need to go for. Kind of ponder your mechanism of injuries, ponder the idea, did they, what's happened in the past couple of days, if this person, looks familiar or they trigger things like that. And it says right here, don't be distracted by seriousness of the situation or frightened by family members. If they're acting erratic in the in the parking lot, PD's on scene, keep your distance. Let the PD make sure that the patient doesn't have any harm, items, weapons on them, but always be cautious of hands, feet, mouths, stuff like that can still hurt you. Sure, your NOIs. Oh, we know they're going to be clues. Look around the environment. Is there any triggers that, like, if there's a pile of clothes sitting over there, just walk over there and mess with them. If the patient doesn't like that because that's their property, they're going to let you know. But what you want to look for is if there's potential medication in there, or if there's very cautiousness as you're going through it, and there's drugs like some needles, or you find some recreational drugs that are maybe in there that could give you some signs and symptoms. If the patient's covered in urine, that could give you an idea that it could be alcohol, it could be a seizure, even just as easy as somebody standing by and be like, "No, bro, I saw him seizing for like 5 minutes. That's when I called." Well, call came in at 8:20, and then you got there at 8:50, 8:35. Let's think about that. So that's 15-minute response time. So he could have had time to go post-dictal and come back. Now his attitude's different. So let the scene tell you a few things. You're not gonna know right off of what I've kind of told you on if there's any kind of previous medical conditions, unless you recognize this person from being a frequent flyer and or a just you've seen them in the hospital recently, because as we transport, we see people everywhere. We kind of recognize and be like, man, that guy looks familiar. Maybe you've seen him in Walmart before, even on your time off. So, and if you're asking family or anything like that, when were they last normal? That's important. If it's a bleed, that gives you the time. They're like, oh, well, last time I saw him was at 1 o'clock today, and he was fine then. Well, it's 8 o'clock now. That's 7 hours. I got to figure out when the hell they started at. So that can help you with your timeline there. Patient assessments. If you can get close to them, that's fine. We know if we see any type of the rapid, life-threatening conditions, we stop and treat that right then and there. If you have to perform a rapid assessment because it is critical, then do your critical assessment. If you can stay and play and do a non-critical assessment and it takes you 15 minutes, that's fine. That's okay. We know our acronyms. We know, hopefully you guys are looking at these patient assessment sheets, your National Registry checkoff sheets. I hope y'all printed them out and you're playing with them on a regular basis. You're looking at them as you're getting dressed, or as you lay in bed, you pull it up on your phone, tablet, or something else, and you're repeating it in your head. Not only repeating it, but eventually you're going to have to do it when you go to boot camp. So I want you to be, if you haven't already, please, please, please start. That's going to very much help you guys. So your initial impression, I've told you before, go with your gut impression. If your gut impression tells you this person looks sick, then do it. Go with that gut impression. You look for your APU on your level of consciousness, alert, verbal, painful, or unresponsive. So when you make your chart, you know where you're at. You remember what status the patient was in. Right here where it says you should be able to tell if the seizure took place, going back over everything that we've talked about, you may be able to form an impression, or if you're familiar with seizures, as some of you guys have stated, you may be like, nah, bro, that dude had a seizure. Let me tell you why I know he's had a seizure, because of that. Probably gonna go with what you say, be like, all right, sounds like he's had a seizure. So on your airway, check them out. Be like, hey, are you going to be able to answer questions? Tell me what's going on, and are you doing it correctly? So you can check their mental status. The thing like, hey, buddy, how's it going? And they don't answer. You be like, hey, well, what's going on today? I don't know. They called me. All right. Well, first off, he's breathing because he said something. He's talking, and he's at least oriented. So if they're able to respond to you, your ABCs are good. If they don't answer you, or they're potentially unresponsive, you got a duty to act. You got to be able to try to fix that, because you have the knowledge and the ability to fix this. So check for any foreign body obstruction. Make sure there's nothing in that mouth. Make sure they haven't tried to swallow something that got stuck. Remember, no digits in the mouth. No hands. No fingers. I don't know about putting a hand in the mouth, but don't put your fingers in their mouth. When you assess their breathing, make sure it is regular rate, regular depth. Is it normal, or is it irregular? You just assess these things. You want to know them, so when you write your charts. If you gotta ventilate them, be very cautious on hyperventilation of a patient, because you can cause more harm trying to properly ventilate them, because you're trying to hyperventilate them. Okay, well, I need to breathe. Well, you need to bag them as you're breathing. If you're taking a deep breath, you breathe through them. If you're exhaling, let off. Those things will help you. And it says hyperventilation may have negative consequences. You have decreased cardiac output. You got all these things that you have to think about. So if you start hyperventilating the patient, you're going to have further brain injury, because it's right there, intercerebral bleeding and increased intracranial pressure, because you're blowing the air somewhere and you're pushing them. So you're pushing them for hyperventilate. So breathe and bag at the same time. Right here, this is going to be a question, I can promise you. Deliver each breath during a period of 1 second at a rate of 10 to 12 breaths a minute. I promise you that's going to be it. Circulation, check for a pulse. If there ain't one, what you gonna do? Start CPR. We know that. If we don't know that by now, we probably should have a talk, and we'll talk on the side. But we know that. That's our process. No pulse, we need to make the heart beat, so we should start CPR. Evaluate the patient quickly if you see any kind of external bleeding. If you see it, fix it. Potentially can be a life-threatening issue, so be very cautious of that. If you see it when you're going through your checkoff stations and you know that to be a life-saving issue, stop and fix it right then. If you got a CPR, during CPR, if you have an AED handy, do apply the AED, but don't stop your CPR. You can manipulate the pads and get them in the right positions, but you don't stop CPR to apply the AED. Important, we know this, we all talk about that. Transport decisions. Notify your facility that you're coming. Get to the right facility in the right amount of time. If you stay and play on a critical patient, it's neglect. So let's not, because that's a chargeable offense, because you neglected to provide a care to the patient. History, we know about this. Talk to the family, talk to bystanders, talk to the patient if possible. If no one's around, look for signs of an AMS. stroke or seizure, is do you see that? Have them say, hey, show me your teeth. If they're able to open their mouth and they're able to, like, they're biting down, they're showing you all their pretty whites, that's fine, that's great. If they're unable to follow directions, or, sir, do me a favor, reach out and touch my arms, and they can't do it, potentially can have a stroke on time. Not just because you're called there because they fell out. Well, maybe they fainted or fell out because they had a stroke. And again, I'm gonna tell you, check that sugar. Don't let that sugar get away from you. We're gonna do our sample to get our full history. It'll help us build our note taking, our history. It'll help build our patient assessment. What are we going to do to these people? Well, if I can get a good sample history, I can help push this out. If you're able to collect all their medications, that's wonderful. If they hand you a bag full of Kroger medicine or a Kroger bag and like, oh, here's all my medicines I take daily, you're just going to have that look on your face like, what in the hell? Collect all medications. Ask the patient if they have a history of seizures, or ask family. It depends if they're around. Secondary assessment. We talked about this several times before. You're going to do a full body, and then you're going to do a detailed assessment to make sure that you're touching every part, limbs, head. If you have to do a rapid assessment, you want to put your hands on them. You want to check for bleeding. You want to check for any type of tissue. If they have a hole anywhere, log roll them on their side, check their back, make sure there's no protruding or bleeding that's hidden underneath the thick wool jacket. So touch these areas, make sure that their extremities are safe and that you've assessed them very properly before you bat them. Put them on a board. I'm sorry. Once you put them on a board and you get going from there and you don't catch it and you get to the hospital and maybe he had a shard of glass sticking out of him and you didn't catch it, they're gonna let you know. They'll tell you. They'll call you out next time you come in. Vital signs are super important. We know if we're checking for compartment syndrome or cushioning effect, or when we check these, we want to know, is it stroke level? Do they have super high blood pressure? Oh my God, we need to make sure we write these down or print out the vital signs when we go into the hospital so we have a history of it. Look for the way that their pupils react to light. Do they react, or are they just very pinpoint? Is one blown and one's normal size? You need to ask the patient, have you had a TBI or anything like that prior, because you see one of their pupils is not reacting. Because that's important on an assessment. We know to check the vitals, 5 minutes if they're critical. Non-critical takes about 10 minutes. Stroke assessment. Do y'all remember what the acronym is that I told y'all a minute ago? I cut you off, girl.
FAST.
That's it. FAST. Correct. I don't think that's a test question. I think that's just the new acronym that's out and about. If you ever get the ability to take a stroke class, there are some very, very good ones. You can see right there. They have the Cincinnati Pre-Hospital Stroke Scale, the Los Angeles Pre-Hospital Stroke Screen, 3-item stroke severity scale. Woo! Get into a history, get into a habit of asking to reach out and touch you, like lift their arms up, push down. Can you pick your legs up? Can you smile at me? Can you answer the question, who's this guy standing right next to me, ma'am? There's the Miami Stroke Screen is a really big one too. Cincinnati's super easy. That's a whole nother class to go into that, but I highly recommend if you can go to one of your facilities and take these stroke classes. They may talk over your head a good bit, but there's some very good information in there, and you can build your own recognizing of these strokes. If you say, okay, well, I want to add that to my ability, or I want to add this, use those things to help you recognize and do your best assessment for a patient. Look at there. Fast, facial droop, arm drift, speech and time. You guys knew in the future what was coming up. There's your table for your Cincinnati pre-stroke screen. If you have facial droop, ask them to show your teeth or smile. Man, y'all must have known I was talking. Arm drift. Can you ask a patient to close their eyes and hold up one arm? Because if you don't want them to see that, that's a very good point. I'm glad I saw that. Close their eyes. Sir, reach up and touch me. All right, good. Thank you. Maybe one arm didn't move at all. If both arms move, that's perfect. Or right there. The sky is blue in Cincinnati. That's very easy to use. If it's right here, patient uses correct words and no slurring. Guess what? That's normal. Abnormal. Patient slurs, uses inappropriate words, or is unable to speak. That's a telltale sign right there that something's going on. That's a good little chart to keep. Here's your little, for the Los Angeles pre-hospital stroke screen. Theirs is a checkbox. Depends on what your agency uses. They may have one that they like better than the other. Hopefully, if you're hiring on for the first time as a basic, they'll put you through an orientation class and go over some of these things and teach you that they want to use this particular screen over this screen. This is why, because our med director likes this. Those are the things that they like to point out. As y'all can see in your book on 17.4, that's really good. So on the lag screen, here's the other part of it. They rate theirs from a 0 to 2. See, and greater than 4 indicates stroke is likely. All right. So all patients with a AMS should have a Glasgow Coma Scale score to be calculated. Does everybody know what a GCS score is? Do y'all remember that? Do y'all know how to obtain one? All right. I think we'll have to cover the GCS score. Bam! Look, y'all knew I was going in the future. So for each one of these, you can get up to a 15. 3 is not technically, yes, that is the lowest you can get, but even a dead person gets a 3. So everybody gets a score here. The best is 654, it's a total of 15. And you rate them. Once you get these numbers, that gives you a total of GCS. Right here, scores 3 to 15 may indicate some mild dysfunction, although 15, the score 15 without neurologic disabilities. 8 or lower, you intubate. That's kind of the thing there. 9 to 12 may indicate moderate dysfunction. Something is wrong. We may not know why or what, but we know something is up. So depending upon that GCS scale is on what we're going to do. If we go to a specific trauma facility, or we go to, oh no, we're recognizing this as a stroke, we need to go to a stroke facility. So that's what I mean by getting a GCS, because you're going to have to give it in your reports, because 99% of the reports I see have used out there in my career, they all ask for a GCS. And we know, again, we're going to reassess everything, make sure that the reassessment is on par, everything's good, and that we continually to monitor our patient. If you do something, you go back and check it. If you splint the leg or you put a tourniquet on there, or you bandage a wound, or you apply direct pressure and you finally got it to quit bleeding, always go back and reassess it. Every 5 minutes, every 10 minutes, when you're doing the vital, I always remember in my head, when I hear the machine start, it's time for my reassessment. If it's critical or non-critical, as soon as it kicks in, even if I'm in the middle of one, I continue what I did, start my reassessment over. It's just a habit that I've done for so long that that machine reminds me, okay, gotta go back and check my IV. Am I still flowing well? What's my drip rate? Have they had any movement on their tube? So you guys can be the same way. Is the tourniquet in the right place? They still have their C-collar, is that hadn't slipped? Are they still attached to the backboard correctly? Things like that. You build your rapport and you start checking on these patients. Is your adjunct airway in the right place? Does their CPAP machine working, or am I holding a good enough seal on the BVM? Those are important things that you constantly need to reassess. and what you saw in the beginning as their baseline. Has there been any improvement? Or has there been any, they getting worse? No matter what you do, how much air you pump in them, how fast you drive, are they getting better? Are they getting worse? And then at the bottom, the last thing you want to do is tell the facility what their chief complaint was at that time, what they called you for, what they said when you walked in the door. Be like, hey, Mr. White, see you here again. What's going on tonight? Exactly what they say is their chief complaint. Now, if they tell you, leave me the hell alone, nothing's wrong, you write your report appropriate the way that you think you should write it, but you need to tell what their chief complaint is. There you go. Call a stroke alert and designate a stroke center if you recognize it early enough. Make sure you communicate what time the last patient was seen healthy, what you found on the neurological exam at the time of your arrival. Note all these times. Even though dispatch tells you that you arrive on this time, you need to know what time you were at your patient assessment. If you can give all those times, those are very, very beneficial to the betterment of the patient. That helps. And if you call the hospital prior to your arrival, just be like, look, I'm about 15 minutes out. Just want to give you a heads up. Okay, now show me about 8 minutes out. That gives them time to start preparing, or they should have already prepared. Communication and documentation is very, 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 very important. Right here, document interventions and patient's response. Did they get better for what you did, or did they not? Patient seized X amount of times in my care during transportation. What you did, write down. Your documentation is the only thing that you have to rely on no matter what. If you take care of a 6-week-old child, transport them to the hospital, until that child is 18 years old, they can go back and sue you, and that's what, 17 plus years? So you're going to tell me if your memory is so good, you don't remember what happened 17 years ago? So that's why document. If you didn't write it down, it did not happen, even if you can very much remember what went down. If you didn't write it in that report, you out of luck. Some emergency care, some are super easy to notify, some to recognize, take care of. Sometimes people just need an ear to talk to, and they call 911 because they're lonely. We know that happens. ED physicians determine if the bleed is in the brain for the patient to be suspected of a stroke. CT for the head, that's going to help. We talked about the clot dissolving medication, maybe get if it's anywhere from 3 to 4.5 hours. See y'all, remember that one. Since y'all sent it to me. It's maybe easy to recognize that stroke, man, if you walk in and be like, what's your face falling off your face for? Like the right side of your face is melting off. Well, they can't really say nothing because they may have Bell's palsy. Well, then they're fine, but you automatically went to a stroke and they're like, this is normal. I've had this for like the last 8 years. Victoria, you know I'm right because it's going to happen. So there's your little chart, little box again, tips on patient care. These are just little helpful, tidbits of information that helps you out. Always have the utmost communication for your patient and communicate very well with your patient. That's huge. If you don't talk to them right and you talk to them wrong, they just not gonna. You may get that nasty gram to your supervisor because the way you spoke to them. So I don't know how many times I'll say this or will I keep saying it, but we don't ever see these patients at the best of their times. We see them at the worst. So just remember that even if you're having a bad day and you're working out there on the truck, be respectful, be nice, be courteous, be generous, and try to help the patients at the best you can. Patients who have had a seizure require definitive evaluation and treatment. When I was still riding the fire truck here in our city, there was always a house. Went to a guy. He had probably 40 seizures a day. He was functioning, but he wasn't able to function out in public. Very educated guy, but he couldn't function because of his seizures. His mom would always call us to come help her with him having a seizure, but she would never let us transport him. We never really ever understood what was going on there. Multiple times a call to, Department of Human Services and stuff like that. So you may just have to protect that patient if they quit breathing, maintain their airway. So somebody's like that, they keep calling you. You may be there just for the safety and the care of that patient, but you may time and time again not transport that patient because it's just because they had a seizure doesn't mean that somebody within the family or a caregiver is going to allow you to transport them. And that's where you're going to have to contact med control and get all these other people involved, and you have to write a big long report. But again, you want to do the best thing as possible. So, for patients who continue to have seizures, suction the airway if they're unable to, come up with, the best way to provide them with oxygen. If they need ALS care, call it early. If you get there and you recognize it, that they're, maybe postictal, you need to get somebody there with ALS care because they may turn around and start it again to where ALS care may have to provide a medication or a higher level of service to them. Most headaches are harmless and don't require medical care. We talked about that. The ones that you really need to pay particular to are the severe, the one that's been lasting for a day or two, maybe longer. Where it says at the bottom, sudden headaches with fever, seizures, AMS, or following trauma. I keep harping on about the car wreck. Make sure that you provide care. You want to ask them questions just because it's super important that we watch that we stay on top of those. And that's something that we can help recognize. If they tell you, yes, I was involved in an accident 24 hours ago, I'm having this constant badass headache, and I don't know what's going on. Help me. I feel like I'm going to die. My head's going to explode. Those are telltale signs of what's going on. And the headache may be out there and maybe a sign and symptom that you see. We talked about migraines, provide a dark and quiet environment. Not real sure how we're going to do that when we are called to be there. I don't know if on transportation, I'll let this say don't use license sirens and all that. I'm going to try my best to say there's other means of transportation besides taking you to the hospital in an ambulance for migraine. Not saying that it's not possible. I know some that have debilitating migraines, but that's just what the book wants to tell you. On a stroke, make sure you always, always, always support the ABCs. If they need oxygen, provide oxygen. Keep an eye on their SpO2, which is their O2 sats. Don't let it drop below 94. If you notice that it is, and you're only providing by a nasal cannula, and at least if it's a nasal cannula, if they're getting below 94, put them on a non-rebreather. Bump it up 12 to 15 liters a minute. That may help them. Just because we're providing oxygen to them doesn't mean that they're going to be oxygenation of their self is going to be great. At the bottom it says it may be in respiratory distress or hypoxic. Just because you're like, oh, okay, I'm going to put 15 liters on them, they're going to be fine. Well, no, because what if they aren't taking full respiratory breaths? What if they're just and it's slow and it's not efficient. It's not supporting life. It's one of those we're going to have trouble with. Paralyzed extremities will require protection. I always like to say if I notice if I'm transporting a stroke patient, I want to put them at a 45 degree, give them the respect, buckle them up, make them sit comfortable. But if I notice one arm is weaker than the other, I'll put it on the inside of the straps. The other one, I'll allow them to move around, reach out, touch things and all that. But if the left arm's in there, I'll put it underneath the strap and kind of hold it in place. And then some of the thrombolytics could reverse the stroke, but it depends on time. Time is a factor. We all know that. If it's a delayed in care, not by us, but a late recognition, we may not be able to get them there in time and to reverse that stroke. So that's something that we got to ponder on. If you notice it's a stroke and or seizure, don't sit there. Don't stay and play. Transport them to the most appropriate facility. If ALS is going to intervene with you, meet them. Don't let them wait on you because you've taken so long. Just kind of get down the road. Put some urgency in you. If your agency says you can't transport lights and sirens, that's fine. Then don't do it that way. But transport that patient with some urgency and get them to the higher level of care. If you may transport them in post-ictal state because you may not see them in the seizures. They may have called you and it took you 20 minutes to get there, and they may have quit seizing. And when they start coming around, they're going to get freaked out because they're in the back of an ambulance, and that's not where they were when they started having a seizure. So talk to them, try to calm them down, introduce yourself. Hey, Mr. White, this is Chris Wally. I'm one of the paramedics with such and such service. You had a seizure. I'm here to take care of everything's going to be okay. Just provide them with that comfort. Continue your ABCs. If you got to give oxygen, give it. We know, we've said it. It's cheap. It's the cheapest thing probably on that truck. Give it to them. Don't withhold it. It's difficult to safely prepare a patient for transportation who's having seizures. It is and it's not, because sometimes it may require to secure them to a backboard, and you're not trying to strap them down to where they can't move. You're just trying to protect themselves. If you have to use C-spine, you can, and don't ever put them in a KED because it's not going to work. I know a guy that put him in a KED and he lost his license because he said the patient was moving too much. There again, never attempt to restrain a patient having a seizure. They will hurt you. And if they break their arm because you're holding it down, and they're going to be flopping it around and hitting it and causing more trauma. So be cautious, very cautious. Just don't try to hold them down. There it is. Not every patient being transported that's had a seizure. They may not want to be going. We can talk to them. We can encourage them, put a control on speakerphone, let them talk to them, try to talk them out of it, talk them out of sign of refusal. But if they just don't want to go, that's their prerogative, and as long as they understand what the potential outcome is, that's on them. It's not on us. Signs and symptoms vary from simple confusion to a coma. It could last days, hours. It just depends. AMS is always an emergency that requires immediate attention because there's something wrong with their computer. We need to restart their computer and or give them something to help fix the electrical fires. All right. Since you saw one of the questions, I will give you guys some other questions to post on the page, and hopefully I can get 14 responses because there's 15 and myself's in here one, so that makes 15. I would like to see you guys respond, give some feedback. You guys are very knowledgeable about this. Unfortunately, some of your family members have to deal with this, and you also help with this. So please, if you can help us, teach us anything, provide any information as a care provider and or potentially as a EMS provider, that would be very helpful. I will post those questions later on tonight, maybe first thing in the morning. Been on the road all day, so I want to digress a little bit. But I know these chapters are so confusing. Please, 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 please message me on the side if you guys need any questions, any help. Try to explain something, break things down a little bit easier. Please let me know of that in time. I'm home for the next 13 days. So I'll be better prepared for Thursday night, and I apologize about tonight and being late and unprepared. But that won't happen again. Thursday night will be on game. I'll give y'all a couple of minutes to ask any questions, post any things that will help us. But I know 14 of y'all are pretty interested in trying to get this code because y'all want to rush off and make hundreds on your test. Sorry, I was just being funny. But I will post your code down in the bottom for everybody to take, use, and go forth with experience. So give me 1 second to start typing this down there. Does anybody have any questions right now? Victoria, of all people, I knew you would have a question, but I'm pretty sure you would message me. All right, folks. So your code tonight is E1 Bravo 2 Charlie 3 W. We might as well say Wally. So that's E1 B2 C3 and W. I don't know if anybody knows what that is or how that is, but I will give y'all an extra pat on the back if y'all can figure those abbreviations out and let me know. I can't give extra credit because I don't even know how to look at your test. All right, folks, I'm going to let y'all have a good evening, and I'm going to shut up for the night. Like I said, if y'all need questions, concerns, or problems, hit me up. Y'all have a wonderful night, and thank y'all for coming.